You can, okay. Okay.
Recording, or it says already recording in progress. Huh?
Okay, good. We are good to go.
So bismillah. So let's start. So this is chest X-ray. So this is a normal chest X-ray. Can you all see my screen?
Not yet.
You can't see my screen?
Not yet.
I'm not sharing. I thought I was. Okay. Share content, share screen. Start broadcasting. Yeah. My screen is being shared now. Can you?
Yes, you can now see.
You can now see my screen, yeah?
Yes.
So can you see the slides? Hello?
Yes, 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 yes.
Is it moving?
Yes, it is. We're good to go.
We're good to go. Bismillah. So we are saying, so we start with a normal chest X-ray. So when you're looking at a chest X-ray, there are chest X-ray anatomies that you must look at. So, and then there are chest X-ray terms or the chest X-ray terminologies that are important. So we start up here. Why am I in this mode? Just a minute. Can you see my cursor?
Yes.
Hello. So we start up here. How I want us to look at is in a manner called ABCDE. So we start with up here, just knowing the normal anatomy. Up here, this is the neck up here. This central hypodensity, this central thing is the trachea. There are these things that is jutting out. Behind the trachea, of course, is the spine, the spinal cord, the thoracic spine at this point. So see these two small things that you can see in the middle are the spinous processes. As you come to the trachea bifurcates here, and the bifurcation of the trachea is called what? The carina. And then as you, so you have to follow the trachea. Is the trachea okay? Is there a normal bifurcation? That is important. Then from there, you look at the breathing systems, the lungs. And when you're looking at the lungs, you look at the lung apices. You look at the lung apices up there. You look at the central portions of the lungs. You look at the lower portion of the lung, especially the lung has the recesses. There is costocardiac recess. There is the heart here, and then there are ribs down here. So there is a recess down here called the costocardiac recess. Then there are the diaphragm here. Then there are the ribs up here. Then there is costophrenic recesses or costophrenic angles. So cardiophrenic angles, costophrenic angles. These are important because when you're looking at a normal X-ray, these costophrenic angles have to be, the word to use is sharp. Are you guys there? Hello?
Yes,
Hello?
Doc.
Yeah, so these costophrenic angles have to be sharp. As we are going to see in the coming cases, you might see there might be fluids up here, there might be other things up here, so the costophrenic recess is not sharp. Then what is this? Are you guys seeing this outline? Yes?
Yes,
What is that?
the breast.
Those are the breast shadows. It's important. Then you are looking at the heart. These cardiophrenic angles have to be, they are usually obtuse. You follow the cardiac outline. Over here, there is, if you follow this heart from this side, then coming up, you remember there are those things that they kept saying in anatomy, 10 things that happen around the carina. One of them is the aorta arches around here. So the aorta comes up here, then it comes down. There is aortic notch here, or we also call it aortic knuckle. There is usually a small space here, and that small space is called the pulmonary bay. So that pulmonary bay is important. All these things I'm mentioning is important. So you look at the heart, how the outline of the heart is, how it is sitting. Then you look at, after that, you look at the ribs. How many of them are visible? Are they all okay? Is there crowding? Is there fractures? Is there other things? Then something that everybody forgets is you look at the clavicles. You look at the clavicles up here. Are there fractures? Are there hypoplasias? Then you look at the scapulae. Okay, then you look down here. Look at the stomach is down here on the right, on the left, and then something else. When you're looking at this X-ray, and you're looking at it, the left side is your right side, and your right side is the left side. Like if I'm looking at my screen right now, this is the left side, but on my right, how I'm looking at it, it's my right, but this is the left side, this is the right side. Okay, so I will proceed. Then as we are looking at this X-ray, even for future discussion, we will look at this in form of this ABCD. A is the airway. And when we talk about the airway, is the trachea and the bronchi. When we're talking about B, the breathing, that is the lungs. When we're talking about C, the circulation, that is the heart and its other features. Then D are the disability. When someone gets disability, usually, as you remember in ATLS, disability is usually fractures and those things, yeah? So just diagrammatic representation, A, B, C, D, E. E is everything. We will come to that. So let's look at these things systematically. Look at the airway. So I'm just projecting. Are you guys seeing my screen now? Hello? Is my screen moving?
Yes, Doc.
Good. So when you're looking at the airway, you're looking at that central part of the lung. So you trace down the trachea to the carina. You can see the carina, the bifurcation there. Is it straight? Is it in the midline? Is there narrowing? Then you trace downward to the right and the left main bronchi. Then is there narrowing? Is there cutoff? Is there foreign body? Anything. So you look at, so that is the first thing you look at when you are looking at the X-ray. So why I'm doing this, why I'm putting these pictures this way is so that you have a systematic way. The first X-ray, when you look at it, your eyes should go to the trachea first. Before you do anything else, is the trachea central? Yeah, are there normal left and right bronchial bifurcations? Is there a foreign body? No, you move to the next. Next thing, you look at the breathing. When you're looking at the breathing, you're looking at the lungs. So you should look at both lungs. Are both lungs well expanded? Yes. Can you count 10 ribs posteriorly? How can you know the ribs are posterior or anterior? So if you look at these ribs up here, they go at this point, they are in the around this area is the spine. So they go back, then you meet them at the sternum. So you count 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. You are supposed to count to 10. Okay. Is one lung larger than the other one? You have to be able to tell the difference. Is there symmetry? Is there area of increased density? Is there? You look at the lung vessels. These things up here. These two things. These are not the opacification. These are just normal vascular anatomy of the lungs. And then, do you look when you look at the lung vessels? Do they branch out progressively and uniformly? Can you see the retrocardiac and retrodiaphragmatic lung vessels? Retrocardiac means you can see them behind the heart. If you look at this, you can see the outline of the cardiac shadow, but behind you can see the vessels. Then even behind this is the diaphragm, the left heavy diaphragm, but behind you can still see the lungs, the lung vessels. Are there extra lines in the periphery that aren't vessels? Those extra lines, I'm not taking you there because I think it's not part of, it's beyond the scope. Again, when you're looking at the lung, you look at the margins of the lungs, you look at the costophrenic angles we've talked about up here. You look at the hemidiaphragms. Are they symmetrical? You trace the cardiac borders. Are they normal? Can you see the descending aorta? I am not seeing it. I am not going to bother myself seeing it. If you are one of those people who want to see it, she does that. Circulation. When you are circulation, we look at the heart, and at the heart, it's not just the heart, but up to the aorta. And the aorta up here, you can see the knuckle. You can see the cardiac shadow on the left and on the right. How you see how this heart is sitting. Then there is some element that we talk about. In patients, especially who have heart disease, we talk about cardiomegaly. When do we have cardiomegaly? This is how you measure. So you look at the widest part of, the widest part of the left side of the heart, you can see from here to there, and then the widest part of the right side. No, this is the left side, the right side. Then you add this up. Then you take the widest part of the lung. Then you divide that length. If it is more than 50%, or in children 60%, then we talk about the fact that the patient has cardiomegaly. And cardiomegaly has many, many causes. Okay. And normally, a third of the heart should be on the left, on the right. The two-thirds will be on the left. And then you check cardiothoracic ratio, check the position and size of the aortic arch, check the width of the mediastinum. What are the causes of widening of the mediastinum, people? Anybody? I have spoken enough. Hello? Hello?
Mediastinal masses.
Mediastinal masses, that is too unspecific.
Specifically?
Yes, widening of the mediastinum.
Thymomas, lymphomas.
Lymphomas. What about aneurysm of the aortic root and the aortic arch?
Mm-hmm. Yes.
What about TB lymphadenopathies? What about sarcoid? Those are the things to think about. Check the width of upper mediastinum. Look at the HeLa vessels. Can you see them both sides? Okay, then look at disability. Disability is just you're looking at the bony effect. Check for the bony pathology, whether there is fracture, whether there is metastasis. Trace along the posterior horizontal rib on one side of the chest. Is there a fracture or abnormality? Repeat with the other side of the chest. Now trace the lateral and anterior ribs on the first side. Repeat on the other side. Hey, okay. Check the clavicle and the shoulders. Look at the cortex of the bone. Okay, this is too much. Finally, check the vertebral bodies. Are they rectangular? Can you see two pedicles per vertebral body? That one probably when you're looking at a chest X-ray, it's not this view that we are looking at. Everything else, can review upper abdomen, soft tissues, stuff. Is there free gas under the diaphragm? Is there subcutaneous emphysema? Is there gastric bubble? Is there hiatus hernia? Can you see that on X-ray? Okay. Are there surgical clips? Are the lung apices clear? I think the part where I am to speak is done. Okay, let's look at the pathologies. I think now is when you people are unmuting. Yes. Somebody, can you guys see the screen? Hello.
Yes.
Who is speaking? Can you take the first picture? Let's say this first picture. Let's give this one. Sorry, let's give this one a name. Can you take picture A? Yes. Let's start. What is that? What are you seeing exactly? That's not really a chest X-ray? I'm sorry about that. What is that? What picture is that? Let's start there. Anybody? Hello?
Scoliosis or lordose
Okay, scoliosis. Okay, so let's agree. So first of all, this is the lateral C-spine or lateral neck X-ray. Then let me just, although this is not part of what we are supposed to do, let me just take you through this. So look at this. So these are the vertebral bodies down here, up here, and then those are the anterior spinal, posterior spinal. So those are the lines. Forget about the lines now. Look at this outline here. From up here, there is an outline here. From down here, there is an outline here. Can you all see that outline?
Yes.
Hello? Eye of faith, people. If you look at this outline, there is this thing here. And this is
Yeah.
here. And that thing is this foreign body. So foreign body in the trachea. So that is it. What about the picture B? This other picture? Anybody? Hello? Yes. Let's follow together. Look at, we start with A. We look at the trachea. There is supposed to be tracheal bifurcation down there. Looking at the ribs, looking at the heart essentially looks normal. It is sitting over here. The lungs look normal. The cardiophrenic angles look sharp. You can see the gastric bubble. But what is this thing? Hello?
The foreign body.
Yeah, where is that foreign body?
In the trachea.
The trachea, where's your trachea? Trachea started up here, then came this way. Then there was a trachea. Do you still feel it in the trachea, or is a bit lower?
Right bronchi, from bronchus.
Thank you. It is in the right main bronchus. Hello, are we all of us agreeing? We move.
Yeah.
Sawa. Look at that. Who will take us through that one? I need people to be talking. Hello? Watu wameogopa? Or I start calling people. We have about 80 people here. Now nobody's talking. You have many people. Sawa. You guys can still see my screen, yeah? Hello?
Yes, Doctor. Yes, you can.
Okay, so let me take, I should not be taking you through this, but let's take you through this. We remember always A, B, C, D, E. You remember? So let's start here. This is our trachea. But what is our trachea doing?
It's deviated.
Yes. It's deviated, yeah? So it comes this way, you can see. Okay, then you can see the trachea down there. Okay, fine. That is our trachea. Then we go to the lungs. The lungs, you look at the costophrenic recesses are normal. The apices look normal. The apices up here look normal. Nothing, no big issues here. Then you look at the heart. The outline of the heart is normal this side, and it's also normal that side. The gastric bubble is there. The ribs, as we can see, to my assessment, all of them look normal. What am I trying to do? What am I trying to do, people? What I'm trying to do is that don't look for pathology. Look at the whole thing. Look at the big picture. So that you don't miss anything. Okay? So that you don't miss anything. I think that is an important thing to think about. So this patient has a deviation of the trachea. Which side is the trachea deviated? Is it to the right or to the left?
To the left.
Hello? Trachea is deviated to the left. I agree with that, good lady. So what are the pathologies that cause tracheal deviation? This one will be in the exams. Hello?
Pneumothorax.
Pneumothorax, thank you. Pneumothorax. So if this patient had trachea deviated to the left, if there was pneumothorax that is responsible for this, is this pneumothorax going to be on the left or on the right?
On the right.
On the right.
Thank you. What about, okay, anything else?
Goiter, multinodular goiter.
Multinodular goiter. How does the goiter deviates the trachea? Anyone who was in the Isiolo medical camp? No, it was Isiolo, the Marsabit medical camp of 2018 or 2019? In that medical camp, there was this lady who was operated and she died. You remember? She had a huge goiter. So what goiter does is, if this is your trachea, or if this is your neck, the whatever, the gland usually sits around like that. So if one side is big, or it can deviate to the side that has less lesion. But more importantly, what are the other things? Let me give you a scenario. This patient has, say, he was in an RTA, has tracheal deviation, and the tracheal deviation is not pneumothorax. What are the other things?
Pleural
Yes.
effusion.
Lung collapse.
Yes. Lung collapse. What is lung collapse, my friend? Lung collapse in pleural, in pneumothorax. What happens? The lung collapses, and then that space that the lung collapses from is filled with air. So the mediastinum is pushed to the opposite side. The other thing, hemothorax can give you that. What other things can give you that?
Lung fibrosis.
Yes, lung fibrosis, thank you. But how is this deviation different from that one of lung fibrosis?
It's the same side.
It's the same
like
side.
where the lesion is where the trachea is deviated to. Yeah.
Thank you. I totally agree with you. But why? Because lung fibrosis, in a manisha, the lung gets smaller. And when the lung gets smaller, because it's fibrous, a vacuum is created, and the body doesn't like a vacuum. So the mediastinum pushed to that side to cover. Now that you've talked about lung fibrosis, or if you examine that patient's chest, what will you see? Outside. Let me give you a more hint. If you look at if you look at the ribs of that gentleman or that good lady who has lung fibrosis, what will you see?
There will consolidation.
Yes, there will be. There's someone saying consolidation?
Yes.
I don't agree with you. There is the word, it's close to consolidation, but consolidation is not specifically, it's not quite the word I'm looking for. There is something called rib crowding, crowding of the ribs. The ribs are too close to each other. The spaces between the ribs become smaller, so you cannot percuss. That is good. So let's look at this a bit more complex. These are 46-year-old patients with history of congestive heart failure. What is your diagnosis? We are still again following that. We're still again following that. What is the word? That format: A, B, C, D, E. So let's start with A. Let's follow the trachea. This is our trachea. This is our right main bronchus. This is our trachea. This is our left main bronchus. What's happening here? Is that a normal tracheal deviation or not? Is that a normal carina or not? Hello?
I think that's normal.
With this one, we are taking a vote. People who say this is a normal carina. Okay, let's compare it with, for example, this. Look at this carina. It came here. It bifurcated like that. And then look at this other carina. Is it normal or is it not normal?
It's not normal.
Thank you. It's not normal. But what is the abnormality?
The abnormality here, Doc, is
Cardiomegaly
there is a
there.
flattening of the cardiophrenic angle has been blunted on that side,
Okay.
on the right side.
We have not quite gotten there, but if you want to take us there, let's go there. So, we have agreed that this thing is. I wanted someone to comment about the carina here. I will go to the cardiophrenic angle.
The right should branch first than the left.
I'm not agreeing with you, Jamal. No. Look at this.
Hello, Doc. I think because of the cardiomegaly, the branching has been affected in such a way that usually the right is the one that is supposed to branch first, then the left. But in this case, the left has been lifted.
The left has been lifted. Okay, that's not exactly the word, but I think you are on the right track. But there's something very simple you guys are not saying. The bifurcation is wider than usual. Is that not? If you look at that bifurcation compared to this other one, is it not wider than the normal bifurcation? It is. Even if you don't agree this, Harper, you have to make a word for it. My word for it. I'm sorry. So there is widening. So widening of the tracheal bifurcation is called splaying of the carina. Do we have 60 years on the call? Yeah. Hello. So I do not want to harass people, but so let me go on. So splaying of the carina is what we are seeing. So splaying of the carina is very specific. Is X-ray sign of mitral stenosis. So in mitral stenosis, there is splaying of the carina. There are other 5 things. There are 5 things that are associated with splaying with mitral stenosis. Splaying of the carina is one of them. What are the others in X-ray features of? So, for example, if you look at this heart, there's this thing they're demonstrating here. There's this cardiac shadow up here. There is a double cardiac shadow down here. So double cardiac shadow is one other thing. You can Google double cardiac shadow. You remember we said there is, when you look at the heart, I jumped. I'm sorry, I jumped. Let's be systematic again. So we have said that on the airway, there is splaying of the carina, we've agreed. Then on the lungs, someone talked about the fact that cardiophrenic angle is obliterated. So let's go through the lungs from up here. It looks normal to me, normal up here. But then there is this shadow of the breast that is confusing some people. So that's just the breast shadow. So I think the lung is normal. But then look at the heart. If you look at the heart, let's start up here from the aortic knuckle. From the aortic knuckle, there should be a small depression there, which has disappeared. Then the heart is enlarged. You follow? Then the heart has 2 shadows. So double cardiac shadow is another X-ray finding in mitral stenosis. Splaying of the carina, double cardiac shadow. Then when you have mitral stenosis, what happens is you have left atrial appendage, or left auricle enlarges. So when that left auricle enlarges, the pulmonary bay that is supposed to be around here is filled with that. So obliteration of the pulmonary bay is another finding. So you will be asked this thing in exams. What are the findings of X-ray findings of mitral stenosis on chest X-ray? One, splaying of the carina, obliteration of the pulmonary bay, double cardiac shadow. And then in this patient, are you seeing something unusual? What is this? Are you guys seeing this?
Yes.
Yeah. What is that now?
It's a mitral valve prosthesis.
Thank you. Moving on. Okay, let's see this. This is what pathology do you see in this patient, and how do we avoid? So let's just do the usual ABCD. I think I've said enough. Can someone take us through this? Is this normal? Is this normal? Are you seeing that? That looks normal to me, yes. Then that is the airway. Then in terms of the cardiac, in terms of the lungs, there is some opacifications down here. So I'm not getting the costophrenic angles are not very clear. The heart is also a bit enlarged. There are all these. There are all these lines. These are instrumentation. This might be an ECG thing. This might be a central line. We don't know. But are you seeing this thing here? Yes. Anybody? Hello.
Yes, doc. Yes.
What is that? Hello. Look at this.
It's coming through the trachea. Yeah?
It's coming through the trachea, and then it's going into the right main bronchus, twisting upon itself, goes back, go to the left main bronchus. What is this? This is a nasogastric tube. So one of your relatives, God forbid, was in ICU. Someone puts a nasogastric tube in the trachea, and then it goes to the left main bronchus. What are the complications? What is the thing that we are afraid of here? Hello,
Aspiration.
people are, yeah?
Aspiration.
That's aspiration, eh? So how do we avoid this? By the way, you guys, mkimaliza, the first thing you do is unaitwa daktari, there's a patient who has low GCS, we need to put a nasogastric tube. You can say, I've never been taught how to put a nasogastric tube. Wendo unaweka. So knowing how to put nasogastric tube is one of the skills you have to know before you go to internship. Or during internship, whichever way. I learned it during internship, so I might know. I did not know when I went there. So this is nasogastric tube in the right main bronchus. How do you avoid this? When you put a nasogastric tube, the first thing is you have to aspirate. And the aspiration, you have to aspirate a gastric content. If you don't aspirate, if what you aspirate is not a gastric content, you come out. And then plus, if you are putting a foreign body in the bronchus, the patient will cough like hell. So when they cough, you stop. So how to avoid? Aspirate, aspirate. Next, I think that's about enough for airway. Okay, let's talk about breathing pathologies. Lungs. Somebody, what are you seeing? A 28-year-old border who was involved in a road traffic accident along Gong Road, presents with chest pain and lowest PO2 of 76% in room air. What is your differential diagnosis? What is your management? Hello? Somebody, can you see the screen? Hello?
Yes, you can.
Yes, Dr. Yunnis, yes, we are seeing it.
Okay, you guys need to learn to go through. So that is around here is the trachea. But that trachea to me is not even central. It is more to this side. Then compare this side of the lung and this side of the lung. What difference do you see? Yes?
the right side is less dense compared to the left side.
Okay, I agree with you. So between the right side and the left, so the right side is less dense. What is this thing?
Doc, I think that is the lung which has collapsed.
This is the lung, yeah?
Yes.
I agree with that gentleman. So this patient has a collapsed lung. There is an empty space hapa katikati, because how can you know it's there? There are no lungs there. You do not see the opacification. You do not see the lung vessels. So the lung is this little thing. So what do we call this? What is the diagnosis here?
Atelectasis.
Atelectasis. Atelectasis, I agree. But something more, there's something I'm looking for. Yeah. When there is no lung in this space, what is in this space?
Pneumothorax.
Yeah, thank you. This is pneumothorax. What kind of pneumothorax is this?
Tension.
Tension pneumothorax.
Tension. Why do you say it is tension? Because the trachea is pushed this side, so there is shift of the mediastinum. So our diagnosis is tension pneumo. What is the treatment for tension pneumothorax?
Chest tube thoracostomy.
Chest tube thoracostomy. I agree with you, but what is the immediate management? Immediate, like if before you look for a chest tube, can this
Needle
patient
decompression. Needle
Yes.
decompression.
Yeah, you do needle decompression. Thank you. I agree with you on that one. Good. I like that. Another one. A 43-year-old man from Gidurai with 4-week history of productive cough and poor appetite came complaining of chest pain on the right with easy fatigability. What is your differential diagnosis? So let's go through again. This is the trachea is there with the bronchi, I think looks normal. Then look at the lungs. Look at the lungs on this side. I think it by and large looks normal. What about on this side? What is the trouble here? Yeah,
There is a blunting
there's blunting of
of the lower base. The costophrenic.
The costophrenic angle is not visible.
Yeah.
So and then there is also there's this opacification up here.
Yes.
So
there's also
what is happening? And then are you seeing this? Are you seeing this meniscus?
Fluid menisci, yeah. Pleural effusion, maybe.
Yes, it's not maybe. This is pleural. Pleural effusion is the correct answer. So this patient, based on history, why is this patient having pleural effusion? A 43-year-old man from Gidurai, 4-week history of productive cough and poor appetite, chest pain, easy fatigability. The man is from Gidurai. He has so Gidurai is a slum, is important. He has 4-week history of productive cough plus poor appetite. What is that for 4 weeks?
Pulmonary tuberculosis.
TB unless proven otherwise. There are those 4 things in TB, cough, fever, poor appetite, and then what else?
Weight loss.
Weight loss. Yes. So those 3 things. So this pleural effusion. Why is this not, for example, hemothorax or pneumothorax? Because this, you see, the pleura is divided into the visceral pleura around the lung and the parietal pleura. So the space between the visceral pleura and parietal pleura is where the fluid collects. So it's important for you to see the meniscus. So the meniscus tells us that there is pleural effusion. So what is the most important test for diagnosis of this condition? How do you diagnose TB is the question. The most important one is you do TB, gene
expert.
Sawa, good. That's good. We have a 30-year-old male who was involved in a right in an RTA came complaining of chest pain and difficulty in breathing. What's the next step in management? What is your diagnosis, first of all?
Pleural effusion.
Pleural effusion.
A pneumothorax.
A pneumothorax. I like the fact that people are starting to pick correct answers. One, let's be systematic. This is the trachea and it's moving this way. There's a bit of tracheal deviation, I agree with you. Then this side, the lung by and large looks normal. And then come here. Look at this. You see this shadow here. What is this? Or are you guys not seeing that? What is this?
That's a collapsed lung.
That's a collapsed lung. Thank you. So here there is a pneumothorax. And then do you see this? Yeah? Where's our cardiophrenic angle? Costophrenic angle?
It has blunted.
And then do you see this? This air fluid level here? My friend, we don't call this meniscus. What do you call it? Air fluid level. It is air fluid level. So, so this tells us there is what's happening here. There was an RTA. Is there pleural effusion? There are two things.
Not really.
Hemothorax.
Hemothorax, thank you. And pneumothorax, because there is a collapsed lung. So this patient has pneumothorax. What is the next step in management of this patient? Tube thoracostomy.
Just tube.
Yes, just tube thoracostomy.
So just tube. Next, a 74-year-old male alcoholic came with fever, altered mental status, difficulty in breathing for 7 days. He coughs, and the cough is productive of brown sputum. What is your diagnosis? We again follow. Then look at this lung. What's happening in these lungs? Yes? What's happening in these lungs?
There is consolidation.
There is consolidation, opacification, consolidation. What's the difference? Consolidation is an examination finding. Opacification is an X-ray finding. So I agree with the lady who said opacification as opposed to consolidation. So opacification where? Hello?
Mostly at the lower lobes.
Mostly at the lower lobes. And let's start with the right side. Where is opacification? Where is it? I think it is generalized. It's all over the place.
The opacities are.
It's generalized. It's all over the place. And here, especially around this area, there is a lot of opacification. Yeah. So diagnosis?
Pneumonia.
Pneumonia. What kind of pneumonia?
Community acquired.
Community acquired. Community acquired is why are you saying community acquired? So when we are looking at X-rays, there are two types of pneumonia. There is Lobar, and which is the other one?
Bronchopneumonia.
Broncho. Is this Lobar or broncho?
Broncho.
Broncho.
Yeah.
This broncho because it's affecting everywhere. I will show you Lobar pneumonia. And then what other things that tells you this patient has bronchopneumonia as opposed to Lobar pneumonia? What are the patients who get broncho? Yeah.
Mostly pediatric population.
Pediatric population. Thank you. I agree with that. More. Look at this patient. How old is this guy?
Elderly. Yeah.
And then this guy, and then he's alcoholic. So this guy is immunocompromised. So guys who are immunocompromised get bronchos. And then which is a specific bacteria that is associated with bronchopneumonia in patients who are alcoholic. Elderly patients who are alcoholic.
Klebsiella.
Thank you. You guys are good, mashallah. So this bronchopneumonia, I agree. What is CAP 65 in pneumonia?
It's used to grade the severity of pneumonia.
Yeah, it's used to grade severity of pneumonia, and it is used to determine whether we admit patients to ICU or not. Huh? Wait, just go through. What are the three?
This for confusion.
Confusion. If the patient is confused, number one. How do we grade it?
If it is oriented, impaired, or conscious.
And then you
use for the serum urea.
Urea.
More than 6.5 or 7, I think 7.
Urea. R is?
Respiratory more than 30.
Respirate. B
is blood pressure.
BP. Is it high or low?
Low.
Low.
So 65 is what?
Age.
I think there are only 3 people talking. So I think I agree with you. That's okay. Here we have a 41-year-old HIV positive patient who came with. Hello. Yeah. Someone HIV positive blood sputum. You are saying miliary TB. Hello.
Yes. Miliary TB.
That looks like a miliary pattern.
Yeah, this is miliary TB. So I think here people know, so we jump. But it gives this millet-like appearance. And then don't jump. Please teach yourself. Always remember ABCDE. Sawa. Tafadhali.
Sawa.
So moving on. The people who are jumping now, you can jump. A 61-year-old male who was treated for TB 4 years ago complained of chest pain and cough. What is your differential diagnosis? Let's start with picture A. Who will take picture A? Picture A. Let's go through again. What's happening? Okay. So let's go through. There is this. Is there a mass here? I don't know. But then there is that. There is there. So then that is the airway. Then look at the lungs. Look at the lungs up here. Costophrenic angle clear. Costophrenic angle also clear on this side. But what is this? Yes, what are those?
There are opacification in the apex, the lung apex.
Yeah, there is opacity. Is this an opacity, or is there is a ring enhancing thing? But the center, is it opacified, or is there a cavitation?
That's a cavitation.
Cavitation.
TB cavitation, eh?
Bilateral apical cavitations.
I like. So the TB usually have apical cavitation. And then come to the picture B. Let's go through again. There is this. What's happening there? There's what's happening to the trachea? So
yes, deviation.
There is deviation to the right. Okay, good. I agree with that. Okay, then come to the lungs. Come this side. You can see, okay, by and large looks okay. Here also the angles look okay. There's a bit of opacification ukuchini. But are you, ladies and gentlemen, seeing this? What is that?
Aspergilloma.
Yeah, that's Aspergilloma. How can you tell it's Aspergilloma, not TB, or not say a metastasis? Look at the cavity around it. Look at the cavity around it. You see, this is the mass, but then there is that space, that black space around it. Yeah. it is, you say aspergilloma usually is seen in a TB cavity. So the space that is left by the cavity after you treat the TB, that is where you find aspergilloma. What is the causative agent of this? Causative. What are the causes of all the aspergillus diseases?
Typically, it's
Yes,
Aspergilloma fumigatus, but you also have other.
Someone said aspergillus flavus. Where hakuna aspergilloma fumigatum, but it's aspergillus fumigatus. So aspergillus fumigatus is the causative agent. What about aspergillus flavus? Aspergillus flavus cause allergic aspergillosis. Even aspergillus fumigatus can cause allergic aspergillosis. So, but you can have in patients who are very immunocompromised bronchopulmonary aspergillosis, which is hard to treat. But these aspergillus fumigatus, usually this aspergilloma, you get it in post-TB patients. It's very common. This one you actually, how do you treat this patient, by the way? Yeah.
Antifungals for 6 months, itraconazole. If not, lobectomy can be done, I think.
Yes, you actually send these patients to cardiothoracic surgeons. They go and remove that mass. Okay.
Doctor, I have a quick question.
Yes.
Sorry for the interruption.
No problem.
Sorry, there are instances where you can have an aspergilloma without the context of HIV. So whether you are on immunosuppressive therapy, I think I'd have a problem being able to identify that on a chest X-ray, because at least for this one, you've said the pointer is that you have the aspergilloma within the cavitation within the cavitation that had been occasioned by the mycobacterium. But in the absence of mycobacterium, how else would you be able to tell that this is most probably from an aspergilloma and not any the other causative pathologies?
If I'm being absolutely honest, aspergilloma is actually not the correct diagnosis here. If we did not have this history. So if you have this figure the way it is minus the history, you will say there is an apical lung mass. Differentials could be aspergilloma, and then it could be lung mets. It could be other things. So you cannot. There's no specific X-ray feature that can tell you this is aspergilloma and nothing else. But then here you correlate with clinical findings. But these patients, specific patients, and of course, diagnosis of aspergilloma is histological. You have to stain the fungus and say, oh, this is aspergillus. But in a patient who is post-TB complaining of chest pain, sometimes they can have hemoptysis, and then you do a chest X-ray, you find something like this. I can argue it's aspergilloma, but there's no other more specific diagnosis. Is that helpful at all?
Yeah, it is helpful. So in other words, you're saying there's no pathognomonic
feature. Yeah.
Yes, there's no pathognomonic feature of an aspergilloma on a chest X-ray. So you have to correlate with the history that you have.
Correlate with the history. Thank you.
Thank you.
Next, spot diagnosis. I'm not saying anything.
Cannonball metastasis. This mets.
These are mets. Oh, there are people who have built this thing. My slides, I think they leaked before. So, so these are cannonballs. So these are called cannonball appearance. These are features of pulmonary metastasis. What are the etiology of these metastases? Yes. What are the common tumors that metastasize to the lung is the question I'm asking.
Choriocarcinoma.
Choriocarcinoma.
HCC.
I don't like
Let's
people.
start with the basics.
I don't like people who say choriocarcinoma. We start like this. Are you seeing my screen?
Yes.
What does that remind you of? You have never heard of something called benzene ring? Benzene. So what is down here? If it is a man, if it's a man, it is prostate. If it's a woman, cervix, cancer of the cervix, cancer of the prostate, then kidneys, or even by the here down here, you can also have testicular tumors, although it's choriocarcinoma is one of the testicular tumors. What's up here?
Breast.
What's up here? Yeah.
Thyroid.
Thyroid. Also, upper katikati you can get even hepatocellular carcinomas. Kidneys you get renal cell carcinoma is the common one. Breast, I think. So you remember it like that. Think of whenever someone asks you cancers that metastasize to the brain, cancers that metastasize to the lungs, even the liver. The cancers that metastasize are these: thyroid, breast, lung itself, renal cell carcinoma, prostate CA, testicular or cancer of the cervix. What else? Those. Okay. A 38-year-old female with 3-day history of cough, fever, difficulty in breathing. What is your diagnosis? Hello?
Pleural effusion.
Pleural effusions. My friend, are you seeing this? Are you seeing this?
Lobar pneumonia.
Who is saying global pneumonia?
FGO is saying global pneumonia.
It's fine. I agree with you. It is lobar pneumonia. It's just lower lobe. What is this? What is this thing that divides the upper lobe and the middle lobe in the right lung? You remember the lung anatomy? How many fissures do you have?
The fissures.
The fissures, So this one is it respects the fissure line. So this is lobar pneumonia. Commonest cause of lobar pneumonia. It has pneumo in its name.
Strep pneumo.
Yeah. I think we are done with the lungs. Okay. 29-year-old female with infertility. Jamal, please don't speak. What is your diagnosis? We go through.
Dextrocardia.
Dextrocardia, yes. Why infertility? Why is infertility a clincher? Hello.
You have problem with cilia.
Yes, immotile cilia syndrome. What is that?
Yeah.
What's the name?
Kartagener
syndrome.
Kartagener. What are the other things in Kartagener? You can get situs inversus. You can, although situs inversus is a thing on its own. You can get infertility. You can get
ectasis.
You can get bronchiectasis. You can get all those things. Okay, I think have we seen this before?
Yes.
Yes.
What is our diagnosis?
Mitral stenosis.
Mitral stenosis. Okay. Okay, good. Okay, I'm jumping this one. We are coming back to this. Spot diagnosis. What's happening? Let's start. What's happening? Yeah?
Pericarditis.
Pericarditis. Who is saying pericarditis? Why are you saying pericarditis? Okay, let's go through this. To be honest, I don't see the trachea. Just up here, naona kidogo, but I don't see. But then, what I can see is the lung on this side. I'm not seeing the full of it, but the cardiophrenic angle looks okay on this side. And then the cardiophrenic angle on this side is lost. So you are looking at the you are looking at the arrow, so you have forgotten to look at the image. So There is a small pleural effusion. Do we agree? Ladies and gentlemen, do we agree or am I making this up?
Yes.
And come to the heart. This is the heart shadow. Can we agree?
Yes.
Yeah. Is it normal?
No.
Not really.
Pericardial effusion.
Pericardial effusion. I agree with that good lady who said pericardial effusion, but she's jumping ahead. She's jumping the gun. But let's just follow. Yeah, I agree with you. But there is that, and then there is that. There is okay. The heart is there. It's up here. But then there is this rim of fluid around it, hypointensity. So what is this? Pericardial effusion. I agree with you. Okay. Come to this. Come to this. A 36-year-old male who was in an accident, he's hypotensive, complains of chest pain. What is your differential diagnosis? Ladies and gentlemen, what's your diagnosis? Fine, let's do the right thing.
Cardiac tamponade.
Cardiac tamponade. Where are you getting tamponade, my friend? So let's start with the trachea. So this is the trachea. This is the trachea. What's happening to the trachea? What's happening to the trachea?
Deviation.
A slight deviation to the right.
There is deviation. Stop looking at the big things and forgetting the small things. Moving on. So the tracheal deviation we have agreed. That's good. Look at this. Look at the lungs. Come up here. There is some opacification, but nothing really huge. Forget about that. This side also come this way. Okay. There's some opacification hapa chini, but okay. We can. And then what's happening to this heart?
There is a cardiomegaly.
Huge.
Cardiothoracic ratio is more than 50%.
Thoracic ratio is more than 50. And then there is this. You see that? There's a space between the lung and the heart. So what do we have here? So this is also a pericardial
effusion.
Pericardial effusion with tamponade. So what is the fluid that is in this space? Yeah?
Pericardial fluid.
Blood.
It's blood because the patient is having. This patient was in an accident. So what is the next step in management of this patient?
Pericardiocentesis?
Yes, needle pericardiocentesis. I agree with you. Then what's Beck's triad?
It's a combination of three things.
Okay.
Hypotension. Muffled heart sounds.
Muffled heart sound. What does muffled heart sound?
And distended neck pain.
Muffled heart sound. What does that mean? Muffled. The heart sounds are quiet. They're quiet. Why? Because there's a fluid around it. So the heart sounds are distant. If you say distant heart sounds, I agree with you. If you say muffled heart sound, I agree with you. Why are there distended neck veins? What is the trouble with cardiac tamponade? Why does it kill a patient? Because the outside fluid restricts the contraction of the heart. So the heart, the relaxation of the heart, so the heart doesn't expand. So the venous return is reduced, so the blood remains in the veins. Why is there hypotension? Because the heart is not beating properly anymore. So that is the Beck's triad of. We've already gone through this. Okay, what is this?
This is a boot-shaped heart.
Yeah, boot-shaped.
The heart looks like a boot. What hearts look like a boot?
Yeah.
A child with Tetralogy of Fallot.
Tetralogy of Fallot. The T is silent. Tetralogy of Fallot. I agree. So 8-year-old female with easy fatigability and hypercyanotic spells. What are the cyanotic heart diseases? Have you heard of the 5 terrible T's?
The 5 T's, eh?
The 5 terrible T's. Who are those?
You have truncus arteriosus, tricuspid atresia.
Tricuspid atresia.
We have TOF. Transposition of the great vessels, eh? TGA.
Okay.
The last one, TB, total anomaly of pulmonary venous return.
Total anomalous peripheral venous connections, or total anomalous venous returns. Okay, pulmonary venous returns. Sawa. Have you heard of some people Ace and Menga complex?
Yes.
What is that?
Complication.
Is a complication of what?
It's a complication of the
Google loading on.
a cyanotic heart disease. It comes later after the shunt has gone from first it's from left to right, and then it goes from right to left because of the pressure.
So what happens is in cyanotic heart diseases, the blood is going from left, which is oxygenated, to right, which is non-oxygenated. So, such that the oxygenated and non-oxygenated blood mix, so you get cyanosis. But what happens is when you get right to left shunt, I hope I'm saying this right. What happens is that usually the right side of the heart has less pressure than the left, because the left ventricle is larger than the right ventricle. But then because of a lot of blood that's going from the left to the right, from right to the left rather, there is increase in pressure. That pressure is so large that the blood now, that side to which the blood is shunting, become hypertrophic, and so it now becomes cyanotic because the direction of the shunting changes from right to left to right. Okay, classic pathologic findings in TOF. Stupid questions for first years, but go on. What are the classic? The 4, the tetralogy.
It has the 4. They call it prof, with V. Pulmonary stenosis for the P.
Start with VSD like normal people, my friend.
VSD, okay.
VSD.
Overriding aorta.
What is the aorta overriding?
Override the VSD.
Overriding VSD. That's why I'm telling you to start with VSD. So the aorta is overriding the VSD. That is correct. What happens? Yes.
We have pulmonary stenosis.
Yeah, because most of the blood is going to the aorta anyway. So there is it's called supra. So supra stenosis. It has a name, I've forgotten. So there's pulmonary stenosis. I agree with you.
And then as a result of the pulmonary stenosis, there will be a buildup of blood in the right ventricle. Therefore, we're going to have right ventricular hypertrophy as the blood is trying to pump.
Thank you, sir. I couldn't have put it better. Moving on swiftly. A 44-year-old post-TB with long-standing history of easy fatigability. What is your differential diagnosis? Can we go through again? Or you guys have already seen the pathology? Yeah? Hello?
Let's go through it. Look.
Okay, fine. So let's go through it. So look at the trachea. Okay, looks normal. Something. Look at the lungs again. Looks normal. Fair enough. Okay. The aortic knuckle even sitting outside. But then look at the heart. The heart, in terms of the anatomy, looks normal. Yeah. But there is this lesion around it. Is this lesion in the heart or is it outside it? Ladies and gentlemen, are we there? Yes?
Pericardium.
Is a pericardium. What's happening to that pericardium? This lesion is also the same here. You see, look what you see what's happening? What is this?
Post-TB pericardial fibrosis.
Post-TB pericardial fibrosis. I disagree with you, but you are almost there. I wish you remove. Eh?
Calcification.
Who said calcification? I agree with calcification. This is post-TB pericarditis, pericardial calcification. So this is called calcific pericarditis. This exact photo was in our final year. See, you guys do sports still in final year?
Yes.
So this was a sport question. And this thing, we just came and found that in the exam. What is this? This patient has this. What is your next step in management? Like, what is this? Okay, so now you know this is pericardial calcification or calcific pericarditis. Moving on, a 49-year-old with history of severe crushing central chest pain. What's your differential diagnosis? We go through again? Hello? Yeah, let's do this. Normal trachea. Normal outer line of the lungs. Technically, normal outer line of the lungs, even on the other side. Normal outline of the heart, Chuko. But what's happening to that mediastinum? What is this? What on earth is this? Is this normal?
No.
It is not normal.
What's happening?
So that is the area supposed to be aortic knob, isn't it?
They are supposed to be the aortic knuckle. I agree with you. Then what's happening here?
An aneurysm.
An aneurysm. Okay, it could be an aneurysm, but something more dramatic than an aneurysm that could happen in a 49-year-old hypertensive with crushing central chest pain.
Aortic dissection.
Yes, it's a dissection. Immediate management. Admit to ICU. Lower the blood pressures. Prepare for repair. Tuko pamoja? Hello? But this
prepare for prepare.
Yeah?
You said prepare for prepare.
Prepare for repair, not prepare.
Okay.
Prepare for prepare.
Okay, thank you.
I actually had a patient like this, one of these big hospitals in Nairobi, where I moonlight sometimes. This guy came in, had severe chest pain. But then the funny thing is, this guy complained that his legs are weak and his legs are numb. Allah. Do an ECG, has features of what is it? Has features of STEMI, ST elevation, myocardial infarction. What will you put this patient on immediately? Yeah.
Nitroglycerin.
Nitroglycerin.
Clopidogrel.
Ninyo wanaume, and you guys are not telling me the things I like to hear. When you talk about MI, what are the things do we talk about?
Mona.
Yes, what is Mona?
Morphine.
Morphine.
Oxygen.
Oxygen.
Nitrates.
Nitrates. What are the two? What are the E's? What are the A's?
Aspirin.
Antiplatelets. Anticoagulant. What else? So here by the way, these things it might catch you in a situation where you don't know what to do. Here is what you do. You give 300 milligram of clopidogrel. Clopidogrel, you give 300 milligram. Oral start. You give aspirin, 300 milligrams. Start. What else do we give? You also give atorvastatin. You give 80 high dose anti what do you call this? What do you call atorvastatin again?
Lipid lowering agent.
Lipid anti what? A lipid lowering, a lower high dose statin. That is the word. High dose statin. So you have agreed this is aortic dissection. And then here, the only pathology we see is what's happening to this mediastinum. Yeah.
Widened.
Yeah, there's widening of the mediastinum.
I have a question.
Yes.
You said we lower the blood pressure.
Yes.
Why is that?
Because if there's a dissection, if the blood pressure gets high, what happens to the dissection? What is a dissection? Let's start there. Yeah. What's aortic dissection?
It's a rupture of the walls of the aorta.
Why are you?
It's a tear, right?
It's a tear. Outside, or is this patient bleeding just into the aortic intima? It's just an intimal tear.
Yeah.
But if the dissection gets, if you increase the blood pressure, the intimal tear can become an aortic rupture, which is catastrophic. So that's what you know. And then this patient, we found the patient has features of enstemy. What are the features of enstemy on ECG? Elevation of a ST segment. Okay, fine. So patient who is having aortic dissection, can you give these medications? Yes, no, I don't know. What are the options? What happens when you give patient aspirin? Hello? Why do you give patient aspirin? To prevent them from clotting. Why do you give patient? Why do you prevent patient? Why do you give patient clopidogrel? So clopidogrel is an antiplatelet.
Yeah.
And aspirin is antiplatelet. This patient is having aortic dissection. If we give those medications, what exactly are we doing?
They will bleed more.
Patient will bleed more. So how do you diagnose? You get an X-ray like this. How do you diagnose? You do something called CT autography. Yeah? You do CT angiography of the aorta. Sawa. Moving on. I think we have seen enough of those. Disability. Let's look at the ribs. Not very clearly. A 27-year-old male involved in a road traffic accident with chest pain on the right. What is your differential diagnosis? Look at those. Why am I taking you there? Let's look at we do the normal things. Normal trachea. Normal lungs. Okay. Someone is finding this so very funny. Then look at the ribs now. We have not been looking at the ribs.
The ribs fracture.
They are rib fractures, eh?
So there's an aspect of flail chest, maybe.
Thank you. I was waiting for someone to say that so that I pounce on them. What's a flail chest? What's a flail chest?
Yes, Dr. Yunnis.
Yes.
That would be segmental multiple rib fractures with paradoxical movement on respiration.
So are you seeing segmental? What is a segmental fracture? So if this is a bone, if you have a segmental fracture, what happens is the bone is fractured here and is also fractured here, so that this segment is sitting on its own. So, sir,
yes.
I'm just seeing one fracture here. I'm not seeing segmental fracture. So segmental fracture of the rib will be a rib breaking at two different places, so that this aspect moves on its own. What's the trouble with flail chest? Yeah. What's the problem with flail thorax? Because when you breathe in, the thorax is supposed to expand. When you breathe in, the flail chest comes back in. And when you breathe out, the chest is supposed to contract, it expands. So there is that paradoxical chest motion, and that one will interfere with your breathing. So in a patient who has rib fractures, who has no other fractures, and they have no other injuries, what is your treatment? Hello? What's your
Sorry,
treatment?
come again, Doc.
In a patient who has rib fractures, they don't have any other injuries, what is your treatment?
Bed rest. And have them rest, have them not move too much on that side, and the ribs will heal on their own.
Pain
But it also
control.
depends on, but it also depends on, sorry, but it also depends on whether the fractures are displaced or not. If they're severely displaced,
you can fix it.
Yes.
Most of the time, the rib fractures are not displaced unless they have other injuries. So most of the rib fractures, you can observe them with bed rest, and not even bed rest. They should do whatever they're doing, but just pain control. Yes.
The session was set at 8:30. I'm not sure if it's going to end. But let's see.
I think this is the last one. No, this is not the last one.
Maybe we can continue with one. We can if it ends, we can continue it with the next session probably from here. If not, we can just finish.
So okay, let me. You were saying I ran through this.
No.
Okay. So what is your spot diagnosis? What's happening with the arrows?
There seems to be a lesion on the bone, on the ribs.
What's happening to the ribs? Is there a lesion? You see a lesion or you see no lesion?
There's a lesion.
This patient
tends on the ribs.
That is rib notching. Hello?
Mm-hmm.
That is the ribs look normal, but they are a bit notched. What is the causative? What disease causes rib notching? Hello? Rib notching, anybody?
Cardiac issue?
My friend, who say where's the cardiac issue? Cardiac funny, what's happening? Cardiac issue ndio kusema nini? I agree with you, but this rib notching is seen in patients with coarctation, coarctation of the aorta. So, if we had time, I will ask you why we have rib notching. What's the diagnosis here? Hello? Hint, this is not what I'm looking for. What's the diagnosis here? Anybody? Let's go through. The lungs. Okay, the lungs. We said we are not looking for the lungs. And then look at the ribs. The ribs look what?
Loaded.
They are what do they look? How what? There are these small rib lesions, but I'm not looking at those. Look at the clavicle on this side. Hello? Are you seeing a clavicle here? Absent clavicle.
Oh.
You are not looking, so you are not seeing. So, a 28-year-old, tunamaliza, a 28-year-old, the last two, a 28-year-old female was involved in a road traffic accident, severe chest pain on the left, has difficulty in breathing with SpO2 of 69. What's your differential diagnosis? We go through again. 1, the trachea is here deviated. The lung looks normal on this side. What's happening to the lungs here? It's compressed by something. What is this? What is this, ladies and gentlemen?
Is it air fluid level?
It is, but what is this?
Collapse.
That would be the stomach. That would be the stomach in the chest. Most probably they have diaphragmatic injury, perforation.
Thank you,
That
sir.
has
I'm
caused
not saying
annulation of the
anything else. Sir, that is it. That is the stomach in the chest. That's called what? Diaphragmatic hernia.
hernia.
Thank you. Moving on. A 43-year-old with features of peritonitis. What's your differential diagnosis? So we're going, we go again. A bit of tracheal deviation, okay, I can accept that. The lungs look normal. The heart outline looks normal. The lungs also look normal on this side. At least this time we're not missing the clavicles. The ribs look normal. But what on earth is this?
Hemoperitoneum. Below the diaphragm.
Air under the diaphragm is the word we are looking for. And the diagnosis is what? Pneumoperitoneum. Pneumoperitoneum tells you what? Where is the air coming from?
Perforation.
Perforation where? In the small bowel. Eh? So patient with peritonitis, do you need to do an X-ray, chest X-ray, or patient even with IO, do you do a chest X-ray? Yes, you do. Why? What do you look for? Not these other things appear, but air under the diaphragm. Air under the diaphragm tells you there is trouble. This is technically not a chest X-ray. What is the differential? What is a spot diagnosis? What is this?
Achalasia cardia.
Achalasia cardia. Diagnose. What are we looking at? What does this thing looks like to you? Or what is this? Yes. What's this?
Bad beak appearance.
Bad beak appearance. What kind of investigation is this?
Barium swallow.
Barium studies, barium swallow. Eh? So bad beak appearance, achalasia cardia. What is the pathophysiology of achalasia cardia? Hypertonic. What? Esophageal sphincter. Treatment.
Myotomy.
Hairless, hairless myotomy.
Look, is there a role of calcium channel blockers in achalasia?
Calcium channel blockers is given. Even what is it? Botulinum toxin is given. Hairless myotomy is done. Huh? There are even people who talk about balloon dilatations, but those ones usually don't work. Any question? Hello?
Are the slides done? We're done.
The slides are done.
Okay. Good.
Where is? Are you people okay? Any questions? Any questions? I thought maybe these are useful. By the most of these things, like a lot of these things, it's criminal not to know. Let me take you through one more time. I have already gone through. All these slides, except maybe one or two, it's criminal. It's criminal not to know there is foreign body. It's criminal not to know there is a tracheal deviation. It's criminal not to know MS. It's criminal not to know you have put a nasogastric tube in the trachea. What is here? What is here? Lung collapse. This is an emergency. It's criminal not to know. It's criminal not to know pleural effusion. It's criminal not to know pneumothorax with lung collapse. It's criminal not to know pulmonary TB and this. All these things you have to know. It's criminal not to pick Aspergilloma. Lung mets you have to know. It's criminal not to know Lobar pneumonia. It's criminal not. This one is not really. Okay. It's criminal not to know this because patient can die if you do not do pericardiocentesis. This one, okay. This one maybe not. This one you can be asked. Criminal not to know this. Again, criminal not to pick rib fractures. This one maybe not. Okay, this one also. Criminal not to know. And also criminal not to know. I think that's all I have to say. Unless someone has any questions, we can stop there. Any comments for those people who have no questions?
Thank you, Dr. Yunnis, for the wonderful presentation. It was precise and clear, and we were able to pick a lot of skills.
MashaAllah. Maybe I was a bit rude with a few people. My apologies. It's not my intention. So, inshallah. And also, I'm not a radiologist. Stop asking me to do X-ray things. So.
Doc, you see, everyone is a doctor, but not everyone is a teacher. So we honestly have learned a lot from you, and rest assured, we'll be inviting you more for radiology sessions, and even
exactly. If it has to be radiology, if it has to be radiology, why don't you guys just do maybe CT scan or MRI of the brain, those nice stuff, or anything to do with spine or the brain? Why you people harassing me with chest X-ray?
You're biased since you're in neurosurgery. You want to take us through story of brain.
Yeah, nice stuff that people know. Chest X-ray, you don't know what this is, but those things you can learn. Like if something is epidural hematoma, it's only epidural hematoma. It can't be anything else. You can't say those for just X-ray. So anyway, mashallah, you guys have been a good what's the word here? Participants. Thank you so much. Barakallahu fikum. I think we end there.
There are a few comments in the chat box.
Or questions even.
Mostly appreciation. Most people are thanking you, mashallah. Thank you so much, Shukran Doc. Thank you so much. It actually shows how much of a beneficial session this has been. We really thank you, Daktari, for putting in the effort to, first of all, spare your good time, again, prepare such a very wonderful presentation. Inshallah, we really are grateful. Shukran sana, Daktari. We'll invite you, inshallah, for more. Anyone with a comment or a question? I think we are finishing. Okay, if not, shukran for attending, guys, and participating. Inshallah, we're going to end it here. Have a lovely night.
Assalamu alaikum.
Alaikum salam. Thank